So welcome back from break. I spent about 2/3 of it being sick. So if I start coughing spontaneously, I'm not dying. I'm just trying to regrow all the epithelium in my larynx after, coughing for a week straight. So tonight we're going to be talking about the history of surgery, and I love medical history. I love the topic, all the threads that connect it from antiquity to now, but I will be completely honest and say this is my absolute favorite, because not only does it involve the history of anatomy, it just involves all these threads we've pulled together before, in addition to cutting people open, which is automatically an incredibly dramatic thing, especially when you think to yourself that surgeons have to think to themselves, I'm going to cut this person open and they'll be better when I'm done. That's a pretty wonderfully kind of gutsy thing to think about. So let's see how we got there. So jumping back to antiquity real briefly, we have Hippocrates. Now Hippocrates, as the father of Western medicine, discussed surgery, but there were actually people alive at the time who were specialists on things like that. And one of the things that the Hippocratic Oath forbids is called cutting for the stone. These are bladder stones. So this stone would just develop and crystallize inside the bladder, and it was pretty much forbidden for the physicians that Hippocrates trained to cut for the stone, one, because it was very brutal and had a lot of mortality associated with it, but it would also have been trespassing on the actual work of the people who were specialists in cutting for the stone. And for the anatomy coherent in here, second years, you've been through repro, if you were to try to take a stone out of someone's bladder, I think the suprapubic approach would be the way to go. Over the pubic bone? No. Perineal approach. So they would try to get the perineal approach right up, grab the stone, yank it out. So we can already imagine how well that was going to go over back in, ancient Greece. Oh, let's see. Jonah, I believe I might have a dead battery going on here. Oh, there we go. Now the next big name that we have in the history of medicine, we've got Galen of Pergamum, living in the Roman Empire, and he started actually as a physician and surgeon, basically doing all of that work, and worked in the gladiatorial arenas, which is a really nice place to see living anatomy back in the day when you're trying to get a sense of how the body's put together, how to suture, how to make things heal back together. And as we've mentioned already, Galen did a lot of impressive things. He described a lot of things accurately, did a lot of research. He described how respiration worked. He described how nerves are necessary to actually cause muscles to contract. He linked a lot of the theories at the time, like the humoral theory and the pneumatic theory, together into a comprehensive system of medicine that was so comprehensive that even though it was wrong, was the mainstay for Western medicine for about 1,500 years, even though there were many errors in there. And one of the errors that's going to come up a lot today is that he thought there was something called laudable pus. Laudable means praiseworthy, and it was his idea that there's a certain kind of pus, a thick yellowish pus, that you actually needed for healing to proceed after there was an incision. So you actually needed that pus. It wasn't just a byproduct, it was something you actively wanted. So he had that as part of his theory. And after he became physician to Roman emperor, he stopped doing a lot of manual labor, wrote a lot, and those theories became very pervasive all throughout the Middle Ages into the Renaissance. Now, as we mentioned during the first and second lectures, the fall of the Roman Empire and its shift eastward into Constantinople was accompanied by a great deal of development in the Islamic societies, and they spread out of Arabia, through northern Africa, through Asia, and in northern Africa they actually jumped into what was called Al-Andalus, which is going to be part of what is Spain today. And one of the people who was practicing in Cordoba, which is part of Spain now, was called Al-Zahari. And Al-Zahari was one of the first writers on surgery. It's often said that the Islamic empires didn't have a great deal of innovation when it came to anatomy and surgery. And in comparison to things like mathematics and optics, that's true, but some development did occur, and Al-Zahari is one of the people who made it happen. In his books, he actually provided illustrations of the sort of tools that were necessary to perform surgery. And even though the Islamic surgeons and physicians were forbidden from cutting the body open, if a cut was already present, they were able to deal with it not only through cautery, which is something that was very much in vogue in the Islamic societies, but Al-Zahari actually came up with the idea of using suture, catgut, to actually suture vessels closed rather than cauterizing everything. Now, sadly, Even though that remained in print, the practice of cautery really outpaced the practice of tying off vessels, which takes longer, it's a little more sophisticated, it's going to be a little more difficult to pull off when someone's actively hemorrhaging. So in addition to cautery becoming primary, there was always a little bit of an undercurrent that the suturing could be there, but it wasn't practiced as much. It was just a theoretical thing that surgeons could do. Now, in addition to writing broadly about dentistry and childbirth, he was able to kind of keep development of surgery going, and especially in Spain, in Al-Andalus, the physicians there were so renowned for being effective that a lot of the Europeans during the Middle Ages actually really tried their best to get medical treatises out of the Islamic societies because it was seen to be a lot more accurate. It was based on more accurate translations of the Greeks, the Romans, and so forth. And actually some medieval European authors would give themselves Arabic pen names to actually get their books to sell better. That's how well it was considered at the time to have that high status background coming from the Islamic societies. So what was going on in medieval Europe after the fall of the Roman Empire is that, sadly, a lot of the practical applications that were developed in the Greek and Roman times were lost, although they maintained that distinction between manual labor and intellectual labor. And where do you think surgery is going to fall on that spectrum, manual or intellectual? Manual. Now I know we've got a packed crowd with ACOS members, people who like surgery here, but think about the stereotypical surgeon. Insert orthopedic in there if you want. What's the stereotypical orthopedic surgeon going to be thought of as? Yeah, hammer first, ask questions later. So that kind of stereotype has kind of stuck around for quite a while. Now in Europe, something that got a little bit cloudy is that surgeons and barbers were kind of considered to be synonymous. In fact, you'll even hear people called barbers or surgeons or barber surgeons, and that distinction can vary from country to country. So it's sometimes hard to nail down exactly what a barber would do versus a surgeon versus a barber surgeon. But broadly, they were responsible for doing things that we associate with barbers, cutting hair, but they also pulled teeth and dealt with wounds. And that's where the surgery side of the barber surgeons was used. It was actually to heal wounds, dress them, even though they weren't doing a lot of cautery necessarily, and definitely not a lot of suturing. They would dress the wounds, try to pack them down with some gauze, and so forth. And because of that, if you were in a mostly illiterate society, how would you go about advertising that you were a barber surgeon who could heal somebody's cut? Can't really put a sign up with barber on it. So what do? You put a pole out front with a bloody rag wrapped around it, and hence the barber pole. That's how the original advertising was done for the barbers and barber surgeons. Now these surgeons, being actually in the field working on things, were really poised to make some real observations and real developments. They weren't really stuck with the academic Greek and Roman authors as unquestionable authority. But the problem is the Council of Tours in the 1100s forbade clergy, and especially monks, from conducting surgery. And basically, these were the only literate people who were doing anything related to that at the time, and they were now forbidden to do so. So surgery became a craft art, not really any experimentation done. You just learned it from the master to apprentice, not a lot of innovation going on, definitely not a lot of recording of innovations and so forth, to the point that the people who conducted it were largely illiterate, making it pretty much stagnant for the majority of the Middle Ages. So what was going on was that we still had that vying of people between the intellectual and the manual side, and some of the surgeons in Paris actually decided that they wanted that same status as physicians. So they started wearing long robes, and they relegated the barbers to wearing short robes. Again, does that sound just a little familiar? Okay, so hierarchy has always been a part of medicine, whether or not that's a good thing. But they were trying to integrate themselves into the academic institutions that had developed in Europe. And in various countries, surgery gained kind of a reputability in various ways. In England, the king actually chartered the surgeons and barbers together with well-defined roles. So the barbers were pretty much restricted to dealing with pulling teeth, doing bleedings, cutting people's hair, giving them shaves. If anybody wants to get on YouTube, I don't think it's on YouTube, but check the internet. In Saturday Night Live in the 70s, they did a great skit called Theodoric of York, Medieval Barber, and it's surprisingly accurate, and you get to see Steve Martin bleeding people, which is automatically hilarious. But the academic surgeons would advertise with the red and white pole. They would handle more sophisticated things like amputations and the treatment of really severe or deep wounds. So we're getting a little bit of a split now between the academic surgeons and the more illiterate barbers who are doing, slightly less complicated things. Now, as usual, you can't have an entire field be completely fallow for hundreds and hundreds of years. There's always a few bright spots. And in terms of medieval surgery, there was a French surgeon named Guy de Chalac, and he studied at Montpellier, one of the great universities in the area, and became actually the surgeon and physician to 3 popes in Avignon. At that time, the papacy had left Rome and had moved to southern France in a city called Avignon, and the plague got there. And interestingly, Guy de Chalac caught the plague but recovered and went on to describe all 3 forms of it, the airborne, the septic, and the pneumonic form, and advised the Pope to basically stay inside his chambers, don't leave, and keep fires burning the whole time, because we didn't know about germs. So why would we have a big fire going in our chamber the whole time? What's that going to help eliminate? Bad air, miasmas. It's going to help get rid of that bad air that people thought might be responsible for the spread of the plague. Oh, by the way, just in case you're wondering about miasmas as sticking around contemporaneously, what's the name of a mosquito-borne disease that affects a lot of people in Africa and the Mediterranean area? Malaria. Mal-area, bad air. So the name of that still retains that connection to kind of miasmatic theory that existed at the time. So he wrote a massive surgical work called Chirurgia Magna, looked at a lot of different ways of dealing with things, and basically was a nice bright spot in surgery at that time. He was familiar with most of the high status theoreticians at the time, so Aristotle, Galen, Al-Zahari, Avicenna, but you remember hopefully, I mentioned laudable pus. He maintained one of Galen's worst errors, and it was that laudable pus was a necessary step to healing. So let's say you did an amputation on someone, and it's healing so nicely that there's no pus. Guess what he'd do? Open it back up, wait for that pus to invade, because they wanted to see that laudable pus. So the infection was actually something people would strive to bring into the process of healing, even if you miraculously got a relatively clean incision. So moving into the Renaissance, we start to get the first glimmer of experimental mindset applied to surgery. The big name for experimental surgery is Ambroise Paré, another French surgeon. And this is his book, The Method of Curing Wounds, made by Gunshot and other things. And this wound man is actually a nice bit of advertising, because how do you want to know if you buy this book, you want to know what sort of injuries you get to treat. Well, good news. You want to treat spear thrusts? Got one right to the thigh there. Arrow shot to the thigh? Yeah, we got that. Club to the head? Yep, they'll teach you how to train and deal with that. So this is a way of advertising what sort of treatments were present inside the book. Now, Paré was relatively poor, came from a lower class background, and he wasn't able to get into university. He didn't speak Latin, and he was excluded from the long-robed surgical academic group. So he did what a lot of people had done to kind of keep moving anyway, and he became a barber surgeon in the French army. The army needed people who would train as surgeons, even if they weren't up on their theory regarding Aristotle, Albucasis, Al-Zahari, etc. They were able to just be there and help out with the army. And during his time in the army, he actually started experimenting with different ways of treating people, not just doing the same thing over and over. And one thing about warfare is it's constantly changing, and the response to it medically has to change also. So this was right about the time that gunpowder and projectiles powered by gunpowder were being put to use in war. And the theory was that if somebody got shot, getting shot's not good, but the really dangerous thing, according to the theorists at the time, was that the gunpowder toxins would kill them. So how do you get rid of the gunpowder toxins? Well, you pour boiling oil into the bullet wound. You're not even really worried about extracting the bullet at that point. You're just pouring boiling oil in there. So just take a moment and think about how well that's going to work. So Paré is doing his best. He's trying to train and do the right thing, and he runs out of oil. And he's like, oh no, this is terrible. And these gunpowder toxins are going to eat these guys alive. So he just comes up with kind of a soothing poultice. I think it involved turpentine and egg whites and things like that. And he checked on his patients the next morning, convinced that he'd probably murdered them because he didn't have enough oil to get the job done. But he actually found they were healing better, surprise to all of us, than the people who had boiling oil poured into their wounds. And instead of just dismissing that, he stuck with it. And that was one thing that Ambrose Paré really embodied at this time, was the idea that you can observe changes and actually improve on the standard of care. And he began researching very strenuously, wrote several books, which became surgical mainstays for nearly 200 years because they were based on his observation and his practical experience as an army surgeon. So he reversed the idea that cautery was the best possible way to deal with wounds. He brought the sutures back. He studied his Al-Zahari and was able to actually figure out that sutures could be a more effective way of stopping bleeding. Characterized syphilis and fractures. And again, if you think back to your reproductive anatomy, he decided that the best way to deal with an indirect inguinal hernia was not, in fact, to castrate the person who had it. Now, if you don't know what that means, I'm jealous, because it's a really horrifying picture when you think about it. A hernia is your intestines moving out through your abdominal wall, and in the case of an indirect inguinal hernia, they go into the scrotum. That's where the testes are. Theory at the time was, well, take out the testes. Does anyone see any possible way that could help? Yeah, me neither, but it was the standard. But thankfully, people like Paré were starting to ask questions and try to actively imagine how they could come up with better treatments. One of my favorite stories about him is that he was so well regarded by the soldiers because he actually took care of the officers and the enlisted equally, that he was actually smuggled into a city that was under siege. And when the soldiers realized he'd gotten in, they paraded him around the streets because they knew that somebody was actually going to try to take care of them. So real quick aside, Paré is a nice example of something that's true in general, which is, as people come up with more and more interesting ways to kill each other, medicine has to come up with more and more ways to deal with those effects. Now, sadly, we don't do it the other way around. We have to go through all the trauma of hurting each other before we find ways to deal with that trauma. But a lot of medical advances can be tied to warfare. In the 1500s, Paré's reintroducing ligature to bleeding arteries rather than just trying to cauterize everything with this massive burning kind of piece of steel. Amputations near the battlefield. In the Revolutionary War, George Washington, it's said, actually probably succeeded because enough of his troops were healthy because of smallpox inoculations. They were actually inoculated with smallpox crusts, and that kept the Revolutionary Army fighting long enough to outlast the British. In the 1850s, we're getting frighteningly close to modern times. Actual nursing was treated professionally, and the Crimean War and Florence Nightingale were the big movers in that idea of not just nursing as an afterthought, but nursing as an actual profession with actual standards and actual cleanliness involved in the caring for patients. Now, during the Civil War, we'll get to this in a minute, we actually have improvements to patient transport, anesthesia was invented, and hygiene became a little bit more of a concern in the hospital setting. And during the 1870s, vaccination, not using smallpox crusts, but using the vaca, the actual cowpox crusts, was used against disease and led to improved outcomes on both sides of that war. World War I, actually a really interesting book called The Facemaker was just published a few months ago about the prosthetics that were generated after World War I to help people with both facial and other limb amputations or deformities so that they could interact socially more easily. And in the 1950s and 70s, in Korea and the Vietnam War, rapid transport off the battlefield, neurovascular repair, and limb reattachment became more and more something that people could deal with on a routine basis, as well as the really difficult thing for people to deal with after the fact was PTSD and the actual psychological trauma that comes along with warfare. And recently in Iraq and Afghanistan, because of the improvised explosives and the kind of just sheer kind of shaking that can occur with these really large-scale explosions, neurologic injuries in the absence of actual acute trauma have become appreciated. So things like diffuse axonal injury, concussions, contusions, and how to treat them has become more and more prominent. All right, quiz time. Hygiene has been one of the toughest things for people to deal with throughout history. And in fact, throughout most of human history, people were left to die on the battlefield because they were probably going to die no matter what, and it was just taking up extra power to move these people up until transport was ready. So, somebody shout out the answer. What is the first American war that lost more soldiers to battle, to actual combat, than to hygiene or food-related causes? Give me some options. What's that? Gulf War. Vietnam. World War I? I can't see that far, sorry. World War II, okay. Okay, somebody actually got it, but it's usually a little bit of a shock to people that some of us were alive for that first war. So the Gulf War, 1990s, was the first time that our supply chain was so well taken care of that disease, foodborne illness, etc., was not the main thing killing people in the military. All right, so back to Ambroise Paré. He had done such a good job through multiple different engagements with the French military that the French king basically insisted that the academic surgeons allow him in and waive their Latin fee so that he could become one of the high-status surgeons. And in fact, he was there when the French king Henry II was wounded really badly in a jousting tournament at celebrating the wedding of his daughter to Philip II, who was king of Spain. So he basically had a jousting pole break, go up under his visor, go through his eye socket and out the back of his skull. He survived initially. He eventually died because it was a pretty horrendous injury. But Ambroise Paré was there and started looking into how he could fix that, or at least alleviate the king's pain. And Philip II of Spain had brought his court physician as well. And a lot of people, if they had a time machine, would go lots of different places. This would be top of my list because Philip II had brought Andreas Vesalius, the father of modern anatomy, there. And the two of them consulted with each other, actually took the heads of condemned criminals and rammed jousting rods through their eye sockets to see if they could figure out what kind of injury had occurred. Now, inevitably, the king succumbed to these injuries. It was a really terrible injury, and the post-injurious infection would take hold and kill him as well. But we had two of the great medical innovators and experimenters in one room right there. So I think I'd be that guy kind of reaching towards the table trying to get a closer look at what they're doing. If anybody wants to get me some Renaissance era capes and gear, we'll take up the GoFundMe later. So let's talk about some specific other countries and how physicians, surgeons, and barber surgeons developed. In England, the physicians, surgeons, and barber surgeons were really separated into their own guilds until the 1540s when Henry VIII, and if you don't know anything about history and you want to think about famous British king, you're probably thinking of Henry VIII. He's the one who had all the wives, started the Church of England, and so forth. He chartered them together and made sure that they had the tools they needed to succeed. The English surgeons got two bodies for dissection each year from executed criminals. In Scotland, the Scottish barber surgeons only got one, but for some reason they were probably doing okay for themselves because they got the entire whiskey monopoly for the city of Edinburgh. Anybody been to Scotland? You say they like to drink in Scotland? It's, fond of it? Yeah, so I think the surgeons did pretty well in Edinburgh. And Edinburgh was not really just an afterthought. The University of Edinburgh had become a major hub for surgical and medical research, and as a result had become a major hub for body snatching. So the surgeons were allotted one criminal per year to dissect. That was nowhere near enough for them to do research and teach. So body snatching became standard, not just in Edinburgh, but it was really well known to be occurring there. Another fun fact is members of the same family held the chair of anatomy at the University of Edinburgh for 126 years. So we've got Alexander Monroe I, Alexander Monroe II, and Alexander Monroe III, spending over a century chairing the Department of Anatomy. Now, the first and second apparently were really good. The third was apparently a terrible teacher And actually, students would regularly go to outside anatomy schools rather than deal with his teaching. So just take a second and think about paying your tuition here, and then at 7, leaving to go to Joe's anatomy school down on 219, which is going to teach you a slightly different way. That's basically what was going on there. So body snatching was obviously not something that people were condoning, but it happened a lot. And so the people of Edinburgh and other areas would come up with ways to try to deal with it. They would come up with basically bells, little traps that would stop people from moving around. They had these things called mort safes. It's basically a cage that you put over the grave until a couple weeks have set in. The body's no longer usable for dissection, and then they can remove the mort safe and take it elsewhere. But burking was never very widely practiced, but it did occur, and it's named for one of its proponents, a guy named Burke. So Burke and Hare were two criminals. Well, they turned into criminals. They lived in Edinburgh, and they were kind of either owners or co-owners of a boarding house. And one of their elderly, infirmed boarders died with no way to pay his bill. So they figured, well, let's just give his body to the anatomists. So they did. And they got a lot of money for it. And they started thinking, like, wow, we need to do this more often. Problem is, people aren't just dying in our house. So being the enterprising fellows that they turned out to be, they just started murdering people who were staying at their house. And the anatomist, a guy named Robert Knox at University of Edinburgh, really didn't ask too many questions about where these fresh bodies were coming on a regular basis, always provided by the same two guys. Now, if this sounds horrible, it is, but it's also horribly funny because they made a movie out of it with Simon Pegg and Andy Serkis. So go ahead and watch Burke and Hare if you're in for a nice little morbid treat sometime later on. Now, eventually they were caught. They got way too confident. They started actually killing people who were well known in town. They were poor, but they were well known, and the students at the school would be like, why is Jimmy the beggar on the table? I saw him like 3 days ago, and I don't know why he's suddenly on the table here. So they were found out. Hare turned evidence against Burke. Burke was executed, and in a nice bit of poetic justice, he was given to the surgeons. And to this day, his skeleton is mounted in the Royal College of Surgeons at Edinburgh, and they bound a couple books in his skin as well. So that's what we have right there in the center. So, continuing with Scotland, we're going to talk about how surgery went from being a necessary but very suspect career to being a high status, very well thought of career. Now, it might be a little difficult to envision, but at the time, surgery was considered a very kind of low status career. And the only way I can really liken that for us today is, who here has worked as an EMT? Okay, got several. Would you say that the world has been overflowing with generosity and respect for your efforts as an EMT?
Last 2 years, yeah.
Last 2 years, okay, we'll go, yeah, so thankfully things might be getting better. But EMTs are good people. They're trying to help us out, get us to the hospital, and most people are very reticent to try to trust them for it. So imagine within one generation, all of a sudden, being an EMT is the most high status thing you can imagine. That's what happened to surgery in the life of William and particularly John Hunter. So, and I should also mention, surgery was low status, but dentistry was considered to be the bottom of the barrel. You were not looked upon well if you were a dentist. All this changed because John Hunter brought what can only be described as a fanatical devotion to research, to surgery. He loved doing surgery, but he really loved doing research on every topic under the sun, not just surgery, but that's where he found the majority of his work being put to use. Now, he had a lot of things going for him. His brother William was a very well-respected obstetrician practicing in London, had a very high-profile clientele, socially very well off, and he had started his own anatomy school, again, one of these private schools to get around the poor teaching that took place in the official universities. He needed more help, and so he brought his younger brother, John, down to London. Now, John had not been academically gifted. John would rather just walk around the country, look at the trees, look at the animals. He had no interest in learning Latin. He went to university for, I believe, a week before he just couldn't take it anymore. But he wanted to help out, and he started working with his brother as an anatomical, kind of doing preparations and prosector, and he was really good. But to have advancement, he needed to get more training. And so he joined the military, much like Paré, and became a surgeon and worked in the British Navy as a surgeon in a few areas. And when he returned, that gave him the entry to various hospitals in London where he could train with some of the higher end people who were there. And a couple of the big names that you may come across after a while were people like William Cheselden, who figured out good, effective ways to do lithotomy, removing stones from bladders, and Percival Pott, a guy who came up with a lot of the orthopedic interventions that were effective at the time. Again, mostly closed. Open fractures were still very dangerous because they got infected, but fixing orthopedic closed fractures was something Pott was very well known for. Actually, you may have heard of a Pott's fracture. It's a fracture of the ankle and lower leg. Pott actually died of a leg fracture, but sadly not a Pott's fracture, just a different one. So Hunter began working in earnest at his brother's anatomy school, and he was a qualified surgeon. He began seeing patients, and he eventually split from his brother and started working nonstop, doing teaching, bringing in house students who would do dissection and learn from him at his house, doing research with those pupils. And body snatching had been present everywhere, but John Hunter turned it into an industry because he needed bodies just coming into his house nonstop for these students, for this research, for the surgical preparations he was trying to do. And it's not completely benign in the sense that he was doing it for the greater good. He was really obsessed with getting unusual specimens in any way he could. In fact, this guy, there's a skeleton, his name was Charles Byrne, and he was a sideshow attraction. Now, he was well over 7 feet tall, came from Ireland, and back in Victorian era England, or prior to Victorian era probably, he did what people would do to make money. He would exhibit himself at a sideshow, and because of his gigantism, his health was never that good, and he knew he was going to die. Hunter had come to see him multiple times at the sideshow, and not being the most socially graceful person, had let slip that he really wanted Charles Byrne's body after he died so he could mount the skeleton. Now, Charles Byrne, being a very devout Catholic, thought that he had to have his body intact for Judgment Day, so he made sure that the undertaker would bury him in a stone coffin that would be thrown into the sea, specifically so that John Hunter would not get his corpse. Here's the problem. There's a skeleton. Hunter counter-bribed the undertaker, followed them out to the sea, and while they stopped at an inn to rest for the night, he swapped out the body with a bunch of rocks, and that's what went into the ocean, and Charles Byrne's skeleton was soon on display in Hunter's museum. And I say museum, it was really his house. In addition to humans, he did a massive amount of dissection of exotic animals. He told all the zoos, all the different private collectors of animals that when those animals died, he really wanted to dissect and kind of see what their structure was like. And this is his house. He had a specially built room just for display of all the specimens that he would dissect, mount, and so forth. My own personal goal right there, house museum. Now, in addition to surgery, he did a ton of work in natural history in general. He figured out that mastodon teeth were distinct from elephant teeth and that mastodons had gone extinct. That was something people really didn't believe in at the time. His papers released 70 years after his death showing that he'd actually anticipated evolution many years before Darwin. Hadn't quite anticipated natural selection, so it's not taking any shine off of Darwin. But those papers were held back by the Royal College of Surgeons because even the prospect of somebody that authoritative backing an idea like evolution was considered to be really radical. Now, in addition to doing anything to get a specimen that he wanted, he was also very willing to put himself under the knife and do a lot of auto-experimentation. So at one point, he had his calcaneal tendon, his Achilles tendon rupture, and instead of doing what most normal people would do, which is baby it, he kind of played around with it to see where the injury was really bad, if it was complete, and it started off a whole idea of tendon repair studies that he did thereafter. He gave the teeth their name. He worked with dentists, so when we talk about incisors, cuspid, bicuspid, that's the terminology Hunter came up with. And a really kind of active debate at the time was whether or not chlamydia and syphilis were two separate diseases or the two manifestations of the same disease. So Hunter did what any sensible, sane person would do. He found a sailor who had syphilis, took some of the syphilitic discharge from the man, and scraped it into his arm and watched to see what sort of symptoms developed. He came to the conclusion that syphilis and chlamydia were the same disease, probably because the sailor actually had both and not just syphilis. So Hunter didn't get everything right, but his willingness to do auto-experimentation came right up to the time of his death. He was having a fight with some of the, not fist fight, but having a verbal fight with some of the administrators at his hospital when he felt himself having a heart attack. He'd suffered from angina for quite a while, and so he felt himself dying, immediately ran to a mirror and started taking down notes on his appearance as he died and just dropped dead right there. So John Hunter did a lot of amazing things, but it's all got to be tempered with this idea that it was absolutely amoral. He really didn't care what he had to do to get his investigations done. And if you find that interesting, this is a really readable book on his life. Doesn't shy away from the good, the bad, and the ugly, and I recommend that, very heavily. Now, as opposed to the gradual improvement of surgery in England, surgery became respectable all at once in France. And it became respectable all at once because of King Louis XIV. Now, just like before, if you can only think of one famous French king, you're probably thinking of this guy. Louis XIV reigned for a very long time. Medically, he was miserable. He had a ton of different problems. It's said that he bathed 3 times in his life. Apparently, he smelled so bad they'd have to throw the windows open whenever he came into the room. So bad hygiene compounding whatever other problems he had. And one of the problems he had was that he had an anal fistula. I'd like to point out again, my children are here, so hey guys. Okay. So what is an anal fistula? Well, it's when an infection in the anal area basically creates a second or third route from the rectum to the outside. It's very painful. Obviously, you've got a lot of foul-smelling material infecting the area, causing inflammation and so forth. And so Louis XIV told his court surgeon, a guy named Charles-François Félix, he said, "You are fixing this, and you're going to do the surgery, and that's that." So Felix had to come up with a way to cure the king's anal fistula without killing the king. So he did lots of experiments. He found peasants who had anal fistulas. He did lots of preparations. No one involved in any of the preps lived. But the day came and he had to go do this operation on the King of France, so he did. And the king did survive. Now, our personal theory on this is, if you're going to operate on the King of France, what are you probably going to do to your tools prior to that maybe you don't do otherwise? You might wash them, make sure they're clean, not because you know anything about germ theory, but because, well, it's the king. So I think there was probably a little bit less likelihood of infection as a result of that. And the king recovered and said, "Oh, surgery is wonderful. Okay, you're a baron, and now there are chairs of surgery at every university in France, and the military has to have a surgeon in every regiment." Boom. So all at once, by royal decree, surgery became very well respected in France, and it wasn't until the French Revolution that that ceased to be, because they just decided, okay, no surgeons, no physicians, we're just going to have health officers in all these areas, both for civilians and for the military, and they will handle both medicine and surgery as needed. All right, so we've discussed how surgery became a little more prestigious, became a little more based on science, on actual anatomical know-how, but it was still awful. People would do anything they could to avoid having surgery done. You could have a dislocated finger, and you would go out of your way for years to avoid having anyone touch that, because there's a real good likelihood that if you went under the knife, you were going to die. So it was violent. It was, not necessarily based on the best science. Post-surgical infection occurred for reasons that no one understood, and there was no way to numb the pain. Now, surgeons, as a response, did the only thing they had any control over. If you can't numb the pain, if you can't control the infection, what can you do to help the person on the table? You can be fast. You can get it done quickly. So surgeons were renowned for really doing their best to do procedures quickly, and quickness doesn't always go hand in hand with hygiene, which at the time was not a major concern. So surgeons would actually, I'm not making this up, it was a status symbol to have a surgical frock coat on that was covered in dried blood and pus and whatever other nastiness had gotten onto you during the procedures. It was actually a status symbol to have the filthiest possible coat on while you're doing operations. If your scalpel falls down, oh, well, we'll pick that back up, maybe kind of wipe it off on the sole of my foot, then go back in, and so forth. It was not in any way, shape, or form conducive to people healing thereafter. So the first barrier that fell was pain. Anesthesia actually became practical, but it only became practical in the 1860s, so relatively recently. So up until then, people had used ice, alcohol, opium, and just, as I said, pure speed to try to deal with the fact that it was painful to have these procedures done. But opium, alcohol, ice, they only can do so much to numb the pain. In fact, Dominique Leray, another French surgeon, figured out that the soldiers who'd been stuck on the icy cold battlefield before being brought in actually did better for the amputations because the cold and the ice had actually numbed their limbs. And he actually had ice brought to the surgical tent thereafter because he realized it went better when he could actually dull the pain prior to the amputations. I should also mention he came up with the idea of ambulances to get people off the battlefield in the first place. So how did surgery become painless? I have great news. This is the first major American contribution to medical history. Yay. That was a really blunted, patriotic display. There we go. But don't worry, the rest of the story is terrible. So, back in the day, in the 1800s, you didn't have movie theaters, you didn't have a lot of things that you could do for fun. So one thing people would do is they'd go to laughing gas parties, which is exactly what it sounds like. People would generate a lot of nitrous oxide, take it to a theater, people would come up on stage, suck down the nitrous oxide, laugh a lot, get silly, and so forth. And in Boston, a dentist named Horace Wells went to one of these. Now, there's a few varying accounts of exactly how this happened, but one of the stories is he was up on stage having sucked down some nitrous oxide, and as he came back, he just rammed his knee into the chair as he was getting back to his seat. But he didn't feel any pain. And the next morning when he woke up, his knee was swollen. He's like, oh, what did I do? He put two and two together and thought, I didn't feel any pain because of the nitrous oxide. I wonder if I could pull teeth using this. And he did. And he was actually able to come up with a fairly decent procedure for administering nitrous oxide and pulling teeth. And being a relatively smart person, he thought maybe this could be even more broadly applicable. So he arranged to do a demonstration of it in front of the students at Boston General Hospital with a really well-known surgeon, a guy named John Warren. And basically, they said, okay, when the patient comes in, we'll administer the gas, we'll do the surgery, see what happens. If it's no good, we just have to do things the standard way, hold the person down while the tumor or what have you is removed. The patient never showed up, so Horace Wells volunteered to pull a tooth from anybody in the audience who volunteered. And, back in those days, a lot of people had a lot of bad teeth, so one of the medical students volunteered. And even though he claimed to have never felt pain, when the tooth was pulled, he let out a yelp. And the medical students lost no time in just ridiculing this upstart dentist who came in, thought that he could show something neat to this amazingly prestigious surgeon, John Warren, and basically they just shouted him out of the theater, and apparently the most damning thing he heard as he left was them shouting, "Humbug," at him. So humbug was a big deal back in the day. So a year later, a student of Wells's, a guy named William Morton, who'd actually had a really long career as a con man and credit thief, had gone into dentistry, and he'd actually studied under Wells. And he thought, this nitrous oxide, it really works. I don't know why the demonstration went badly, but if nitrous oxide works, maybe ether would work better. And he thought that because, in addition to laughing gas parties, people in the day would also go to ether frolics. And an ether frolic is just what it sounds like. You'd get a rag full of ether, suck it down, you'd huff the ether in front of your friends and family, and then act silly, and everybody would have a fun time. But he thought, well, you don't feel any pain with that either. And so he started working on ether as an anesthetic. And about a year to the date, he actually convinced the same surgeon to let him use ether anesthesia. Now this was, again, you had a patient scheduled, but this time the patient showed up, and the guy had a big salivary gland tumor. It was really wrapped around his mandible, very extensive, very difficult thing to contemplate, taking off of a person who's trying to squeamish, kind of squirm away from you and fight the orderlies while you're doing the operation. So Morton applied the ether, knocked the guy out, and when the guy woke up, his first words were, "When are we going to start?" So it was pretty much immediately understood this was a big deal. Painless surgery was something that could really be a game changer, to the point that Dr. Warren looked at all the med students who were there, probably some of the same people who'd been there a year earlier, and is quoted as having said, "Gentlemen, this is no humbug." I don't know if we can pull it off, but if anybody wants to try to bring humbug back in this lifetime, I'd deeply appreciate it. So this was a big deal. The problem is, Morton had a long career as a con man and so forth, and he knew a money-making opportunity when he saw it. So he couldn't get a copyright on ether. Everybody knew what ether was. So he started disguising it with other scents and things, calling it lithion. And a chemist who he'd consulted with at Harvard, a guy named Charles Jackson, said, "Listen, I helped you get the ether. I basically helped you out with this. I did a lot of the work. I deserve equal credit." And the two of them just started attacking each other, demanding credit and priority for this discovery together. Now, Charles Jackson was kind of a weird character. He was convinced that Samuel Morse had stolen Morse code from him and that Alfred Nobel had stolen dynamite from him. So he was already kind of in the place where he thought he wasn't going to get ripped off again in his mind. So he and Morton just started infringing on each other's claimed trademarks to surgical anesthesia. Meanwhile, surgeons around the world knew that this stuff worked. They knew it was ether, so they were just using it anyway, despite any sort of copyright that these guys would try to put forward. So this is the 1860s. So in the 1860s, the government of the United States decided that this massively influential discovery was being tarnished by these two just bitterly attacking each other in the press, and put up $100,000, 1860s, $100,000 to whoever could prove precedent. So Morton jumped in his cab to press his case, but on the way had a massive stroke and passed away shortly thereafter. Now, I've only heard this version of the story once, but it's the best version, so I'm going to give it to you. Just be aware this may not be how it actually happened. But a medical historian and surgeon named Sherwin Newland said that years later, Jackson was attending a funeral in Cambridge, Massachusetts, and as he was leaving, came across the gravestone of this person he hated more than anyone. So he came across Morton's gravestone, which said, "William Morton, inventor and revealer of anesthetic inhalation, by whom pain in surgery was averted and annulled, before whom in all times surgery was agony." According to Sherwin Newland, Jackson went acutely insane right then and there, never recovered, and died in an asylum, several years thereafter. And, to no one's surprise, is buried in the exact same cemetery in Cambridge, Massachusetts. So, a lot of dysfunction. These people brought painless surgery to the world, and yet the discovery brought nothing but pain and horror to them. And on top of that, a guy named Crawford Long, a rural doctor in Georgia, had been revealed to have been using ether in small operations and tumor removals 4 years prior to the demonstration at Boston General, and hadn't really tried to press his case because he thought this was just something anybody could do. But it wasn't until his friend said, "Crawford, it's $100,000. You should really try to write up that you did this." And he's the only one who kind of died with any dignity. Nobody ever got the money, but he just continued his rural practice, passed away while delivering a baby, and maintained a bit of dignity in the process. So surgical anesthesia was in existence, but ether was a really rough chemical, had a lot of kind of caustic and kind of inflammatory activity, and other people started looking for ways to improve it. Now, one of the early adopters in England was a real famous surgeon named Robert Liston. Now, Liston was an interesting fellow. He was huge. He was like, I think, 6'5", something like that. He was one of the greatest surgeons of his time because he was one of the fastest surgeons, and yet he was willing to experiment with lots of things to dull the pain, and actually started using mesmerism to try to get people to undergo painless surgery. The problem was the mesmerists, the people who try to hypnotize the patients, took hours and hours to get them in a state where they could do that, whereas this ether could knock them out just like that. But he knew it was a great innovation and used ether early on. And another great quote from that point So this Yankee Dodge beats Mesmerism Hollow. For those of you who don't speak 1800 Scotsman, that means this American innovation is far better than mesmerism and hypnosis. So he basically knew that this was going to be a big deal. So in addition to adopting ether early on, he was renowned for the speedy amputations he did. He would actually come into the operating theater and say, "Quick, time me!" And everybody would whip out their watch to time how quick the amputation would take. Lower limb amputation, 2.5 minutes was his record. But sometimes there'd be problems. When you're trying to do a thigh amputation, maybe the scrotum gets in the way and you lose a testicle. Maybe one of your assistants doesn't move quickly enough and loses a finger in the process. And as far as I can tell, he's the only person to ever have had a procedure with a 300% mortality rate. Anybody want to hear how that happened? Okay, so he was doing a speedy amputation at the thigh. Got the falciform, big curved knife, wrapped his arm around the thigh so he could do it in one clean big cut. His assistant had his finger in the way, and as he did the amputation, it cut off the assistant's finger. The assistant jumped back, bleeding, at which point Liston jumped back, and his knife went flying into the audience. Didn't actually kill anyone with the knife, but it caused one of the elderly spectators to have a heart attack. The patient and the assistant later died of sepsis from the wounds that they had. Therefore, one surgery, 300% mortality rate. Oh, and one other thing, Robert Knox, the guy who was the anatomist in Edinburgh, bought bodies from Burke and Hare. Never really proven to have known where they were coming from, but he also didn't ask too many questions. Liston actually knew one of the victims of Burke and Hare and actually got into a fist fight in the middle of class with Robert Knox while he was teaching one day. So if you guys, you can throw up your money now, like if you want Dr. Pankey and I to get into a fist fight at some point, we'll put the money towards charity. We'll see how it goes. So ether is well on the stage. It's well known that it works, but it's very inefficient. It's hard to meter out exactly how much is useful. And so surgeons and others started looking for better options. And a guy named James Simpson in Edinburgh started having parties where he and his friends would sniff various chemicals to see if they might have anesthetic effects. And they got to chloroform one day. And as the story goes, they opened up the chloroform, they all took a sniff, and about 20 minutes later, they woke up under the table and thought, okay, this might actually work. And chloroform actually was far less irritating. It was far easier to administer. It knocked people out quicker. It was a big improvement over ether. Now, one quick kind of caveat to that, some people would react very poorly to chloroform and it would actually kill them very quickly. They would have a reaction that was very out of bounds, but it was still a better option than ether and largely replaced ether for surgery. Now, this was not something that people took as well as you might think. I'm sure at this point that doesn't surprise you, but the general public was a little bit suspicious about these chemicals being used in surgery. And in fact, we had flammable gases. That's a legitimate concern. You don't want these gases igniting during a procedure. But some clergy in the Church of England objected to the grounds that if you administered this during childbirth, it would rob God of the deep and earnest cries of a mother in labor. So when people started using anesthesia for childbirth, it was considered to be very controversial until it wasn't. And it wasn't because the Queen had it done. And once the Queen does it, Queen Victoria gave birth to one of her children, Prince Leopold, under chloroform anesthesia. And at that point, everybody pretty much shut up. Like, okay, Queen does that. And it was administered by John Snow, the same John Snow who went and was able to do that epidemiologic study stopping a cholera outbreak in London. So John Snow, a lot of good stuff. You can see the pump that's there in his honor, and you can also see the John Snow pub right behind it there. It's on my bucket list one of these days. So we've got painless surgery as an option now. Surgery is based on actual understanding of the anatomy. So what's left? Well, infection. No one knows where these infections, where these post-surgical morbidities are coming from. And the person who applied microbiology to surgery was Joseph Lister. Now, he was present when Robert Liston first used ether anesthesia, and he was also a very experimentally minded person. And he had one other really great advantage. His father, being a Quaker, was encouraged to have an outside interest that was scientific or literate, and he was a microscopist. His dad actually figured out how to stop something called chromatic aberration, and that's where the different wavelengths of light refract at slightly different angles and cause subject under the microscope to get blurry. His dad figured out how to stop that, and Joseph Lister grew up knowing how to use a microscope, which was very uncommon for medical students at the time. So he started looking at inflammation and infection, and at one point he read a paper by Louis Pasteur and was thinking to himself, wow, these small little animals, these animalcules that Pasteur described are causing the wine to go sour, causing the silkworms to get blighted. Maybe there's something going on with them and surgical infection. And so he started looking at pus under the microscope, and lo and behold, the different kinds of pus that can occur were associated very strongly with specific microorganisms. So what we'd call Staphylococcus was what was responsible for that laudable pus. It stays relatively near the infection site, doesn't tend to spread. Obviously, for us, it's not a good thing, but it's not the most aggressive of microorganisms. Smelly, thick pus was associated with something different, which we now call Streptococcus. It can move centrally, causing red streaks. Sometimes they'd have to do progressive amputations to try to get ahead of that infection. And worst of all, watery, really nasty smelling pus was a result of clostridial infections, and that was called gas gangrene. But he discovered that there were specific microorganisms responsible, and being a smart fellow, he thought maybe there's a way for us to get rid of these, just like Pasteur was able to get rid of microorganisms in the beer and the wine. So he started looking for antiseptic substances, and finally phenol, or what was called at the time carbolic acid, was the one he settled on. So he would spray it on the instruments, he'd spray it on the patient, he'd spray it in the wound. Now, by contemporary standards, it was a lot of overkill, but it was a big step forward at the time. Now, this finding was promoted, and his outcomes, meticulously documented, showed that these infections could be treated this way. Open fractures could be healed, and what was normally a death sentence, if you had an open fracture, would heal up very nicely. People would recover. But the problem was, doing this was against everything surgeons had trained to do. What was the surgeon's main attribute up until this time? Speed. This is not a fast process. You spray the instruments, you spray your hands, you stop, you spray around the room, you spray this. It slows everything down. And on account of that, a lot of people, especially in England, really did not take to these issues. Now, Joseph Lister had something that most of the people in the history of medicine didn't have, which was a great deal of humility and patience. And he just stuck to his research, stuck to his message that this antiseptic method could actually work. And a lot of people around the world started taking it very seriously. And so even though at home he wasn't really taken, his results weren't really looked upon favorably, a lot of places started using it, and the advantages became very clear. One of his staunchest opponents was actually a guy named Dr. Samuel Gross in Philadelphia, a well-known American surgeon. You may have seen this picture before. It's a pretty famous picture called the Gross Clinic. Now, Gross was actually a really well-trained pathologist by the standards of the time, and his thoughts were that infection, disease, and surgery results from oxygen entering the wound, and that's why surgery had to be fast. And this antisepsis was just complete nonsense. So he would do everything he could to kind of, lay down that antisepsis was nonsense, you still had to be fast, but he was wrong. Now take a look at this picture. We've got dark robes, probably encrusted with filth, as I mentioned before. That was the status symbol for surgeons. And the same painter, Thomas Eakins, was commissioned to do another portrait of a retiring surgeon about 10 years after. And here's what surgery had turned into in the meantime. The Listerian techniques had had time to build. Lister was an excellent and, again, very patient proselytizer of antiseptic technique and why it was better, why people should change. And his findings were validated basically because there were superior outcomes. He had a great deal of persistence, and sadly, a great deal of medical and scientific advancement happens because the older generation dies. They're not there to be a roadblock anymore. And that's what happened. Lister's antiseptic methods took over, and eventually became the standard until aseptic technique became even more effective. Why sterilize something when you can simply not allow bacteria there in the first place? When Pasteur retired, actually Joseph Lister was there, and Pasteur was, they had never met each other, but they had this like long embrace on the podium. And Pasteur said, if I had done nothing else with my life but make the discovery that led to your discovery, this would all have been worth it. So Pasteur is very much appreciative that Lister had expanded those microbiologic findings to surgery. So this is the Agnew Clinic, and once again, you can see the changes that came about, within a decade or so after the introduction of Listerian technique. Everybody doing okay? I was going to keep going. Does anyone if you need to do a bathroom break, take your time. Yay, nay, stop, go. Keep going.
Do you need a break?
I've got water. I'm good. What, stop talking? Jeez. All right, so now we're going to talk about how American surgery went from being a backwater to being the standard. Now, as we mentioned in earlier lectures, European medicine was at a much higher standard than American medicine. American medicine and surgery got off to a good start, but the Civil War killed that momentum. The manpower loss, the loss to the economy, and having to rebuild everything really set American medicine and American society back several decades. Johns Hopkins, as we've already mentioned, was a place where innovation was brought in, and the chief of surgery at Hopkins was a guy named William Halsted, and he basically turned American surgery into the standard for the world. He was an early adopter of Lister's methods. He trained in Europe. He was actually from a fairly wealthy New York family and went to all the hospitals in Europe that he could, toured, saw all the latest innovations. And when he came back to New York, he asked the hospital administrators to create a Listerian theater where they could actually do antiseptic technique. He was told no, but being wealthy, he put together a tent on the hospital grounds and made that tent into an antiseptic surgical area with some of his other younger contemporaries. He was doing a lot of research, doing a lot of surgery, doing a lot of partying, just very flamboyant, kind of playboy lifestyle. He was just on top of the medical world until he started investigating kind of topical anesthetics, specifically topical anesthetic that had just been kind of isolated, cocaine. So Sigmund Freud had let a guy named Karl Kohler know that cocaine might numb the mucous membranes, so he could do eye surgery. But Halsted thought, well, these injections of cocaine can also numb the peripheral nerves, and we could do nerve blocks and then do procedures on the limbs and other places. So he and his friends would check and see where they could inject the cocaine to numb their arms. And surprise, surprise, after they injected cocaine, they felt really good. And they'd go out and party for hours and hours because they had this sudden boost of energy. But as we now know, that doesn't come at no cost. And pretty soon, he and his contemporaries, the people who were doing research with him, became addicted to cocaine, were unable to maintain their activities, and basically crashed. It took him years to actually write a treatise about the use of cocaine as a topical anesthetic, and by the time he got around to writing it, he was really fully in the grips of cocaine and very badly addicted to it. Here's one sentence from his paper. Oh, by the way, I should mention cocaine was widely available. It wasn't like you had to go out of your way to find it. Kids crying, give them some cocaine. They're still crying, well, we got some morphine in the other tooth drops. We'll use that too. So drugs, very dangerous drugs, were widely available at the time. So here's one sentence from his eventual paper, and it's just as coherent as you'd think it is. I'm gonna make a go for it. Ready? Neither indifferent as to which of how many possibilities may best explain, nor yet at a loss to comprehend why surgeons have, and that so many, quite without discredit, could have exhibited scarcely any interest in what, as a local anesthetic, had been supposed, if not declared, by most to be very sure to prove, especially to them, attractive. Still, okay, that's enough. That's halfway through this single sentence. So he had fallen from this, being extremely top of the world surgeon to a place where his friends and family thought he was going to be dead of an overdose any day. He was actually able to recover because William Welch, a pathologist and friend of his, had just taken over heading up the medical school at the new Johns Hopkins and brought Halsted in as a surgical assistant and oversaw his recovery and kind of helped him get himself off of cocaine. And Halstead, who had been flamboyant and jaunty, had become a very slow, very meticulous operator, but he was so meticulous, it was said that his surgeries were pretty much bloodless. He'd ligate every artery, every vein, make sure that everything was well tied off, and his surgeries take a great deal of time, but they were meticulous and had great outcomes because he was so very invested in doing a lot of research leading up to it. And when the person they hired to be chief of surgery at Hopkins backed out, Halstead got the job and became chief of surgery there and began tackling problems that no one else had ever thought of with surgery. Hernia repair, actually looking at how you could put the intestines back in from a hernia, seal up the body wall using the various layers of the abdomen to anchor the sutures. Thyroid surgery had never been attempted before because whenever anyone cut into it, it would release what was called a thyroid storm, and the hormones would kind of raid the bloodstream and cause a lot of metabolic problems. He came up with effective ways to do those because he did a lot of meticulous anatomy research, and these were his own drawings, so he illustrated his findings as well. He conducted one of the first gallbladder operations on his mother on her kitchen table with his sister and father acting as assistants because he knew, based on her symptoms, that she was going to die before she could get anywhere else for help. And he was able to do a gallbladder operation on his mother. Mom, I love you. I'll get you to the hospital rather than the kitchen table. And something that he's received a lot of negativity for in recent years is called the Halstead radical mastectomy. So make no mistake, this is not a procedure that people use with any degree of regularity now because we have way better options. But at the time, this was a huge leap forward. Prior to the Halstead mastectomy, anyone being treated for breast surgery would be treated thusly. They'd be given opium to smoke, top left. Spikes would be put through the breast, anchored to a rope, lifted, and then a red-hot knife would be used to cut the breast tissue off, and then cautery would be applied. Think about lymphatic spread. Think about tumors invading deep tissues. Is this surgery going to address any of that? No, so you basically traumatize someone who's going to die of the same disease anyway. So these diseases, especially breast cancer, would cause deep, but also superficial suppurations that would, isolate these people, cause deformity, cause ulcers that would, smell terrible, isolate them from friends and family. And so Halstead came up with the idea that you have to get the lymphatics as much as anything else. And he said, just to be sure, we're going to take off the pectoralis muscles. We're going to take as much lymphatics as possible. And people survived. Now again, it's called the radical mastectomy because you're removing a lot of tissue here. And we have way better options now. Lumpectomies, early screenings are far more effective. They exist. They didn't exist at the time. But this was a procedure that actually worked, unlike everything that had preceded it. Now, just in case you weren't already impressed, he came up with the application of the residency system to surgery. Up until then, you just kind of showed up at the hospital, and maybe you got assigned to do something or not, where senior students trained junior students, who then trained more junior students. That became standard practice. And think about the anatomy lab. Do you guys like your latex gloves? Well, thank you, William Halstead. He came up with gloves. Being a well-placed, New York aristocrat, he said, it really would be nice if my surgical assistants didn't have their hands turn beet red and swell up because of the antiseptic things we're using. So he got the people at Goodyear to make rubber gloves. And the first person who received it was named Carolyn Hampton, his surgical nurse, who he later married. So some people propose with a bouquet or a ring. I think rubber gloves might work just as well. So he had done a lot to promote surgery and make American surgery the standard, the most innovative, the most research-based. But it was turned out that he was very difficult to read. He had a really kind of vicious streak of humor, and he would viciously mock anybody who didn't quite meet his standards. And he would just disappear. One reason people think he was so keen on the residency system was because he could just go away, and the seniors, the chief residents, would be like, well, guess I'm in charge, and guess we're doing this, and he'd always have somebody there to pick up the slack. And the reason is, he never quite beat his addiction. He wasn't addicted to cocaine as much, but he had gotten himself off cocaine by becoming addicted to morphine. So the fact that he was that productive when he had to lose blocks of time where he would go on, for lack of a better phrase, a bender at his country home or other places is really pretty amazing that he got as much done as he did while actively being addicted to this. Now, he had a lot of students, and again, he was a pretty rough teacher. One of his most famous students, a guy named Harvey Cushing. Now, when you think of Cushing's disease, what system jumps to mind? It's an endocrine disease. And yet Harvey Cushing was a neurosurgeon. He actually didn't invent neurosurgery, but during the time of his life, mortality during operations involving the brain went from over 90% to about 8%. He was one of the real innovators using the Halsted techniques and finding ways to do brain surgery and remove tumors. One of his earliest triumphs was actually dealing with trigeminal neuralgia, cutting branches of the trigeminal nerve. I teach anatomy, I should get that straight. The trigeminal nerve that were causing pain to manifest in ways that people couldn't handle. And until he came up with that surgery, the most common outcome of trigeminal neuralgia was suicide, because people would be in horrible pain, unable to sleep, and when you spend weeks not being able to sleep, you stop thinking clearly and will do whatever it takes to get away from that pain. So cutting that nerve may have deadened part of the face, but it stopped the pain. He came up with Cushing's disease, named after him, because he was able to deal with endocrine problems by removing parts of the pituitary gland that might have had a tumor, might have overgrown, and did a lot of things to treat brain tumors, brain diseases, and so forth. And he had a contemporary, a guy named Walter Dandy, who was kind of a back and forth competitor. Dandy described cerebrospinal fluid circulation, came up with aneurysm clips, figured out how a herniated nucleus pulposus could cause sciatica, and he was an early proponent of something called pneumoventriculography. Now, this is a thing I would have never thought existed, but it did. And here's the deal. Back then, neurosurgeons had to rely on a neurologic exam to know where to cut. Basically, they had to do a thorough physical exam and say, okay, pretty sure the tumor is right here. And then they're going to open up that part of the skull and hope they're right. So that neuro exam is all they had to go on. Now, when x-rays came around, it was a big deal because it actually gave them something to work with. But the problem is tumor and brain tissue are not so radically different that you can see that difference on an x-ray. What really helped is if you had air for contrast, but the only thing you had for contrast in the brain was cerebrospinal fluid. So Walter Dandy invented, again, pneumoventriculography, where he would open the skull, drain the CSF, take an x-ray, and then the air inside the ventricles might show him where the outline of the tumor was, at which point he could then do a procedure to go remove part of that tumor. So let's give it up for CTs and MRIs. We don't have to cut our brains open just to see what's going on in our brains anymore. So these two made brain surgery one of the last kind of fields to benefit from surgical advances into something that could be done regularly and with a fairly decent expectation of good outcomes. Now, another thing that happened at Hopkins was the first heart surgery. Now, some repairs had been done, we'll talk about this next time, on the pericardium, some superficial problems that involve the area around the heart or the mediastinum. But the first real heart operation was done on children with congenital heart malformations. Dr. Helen Taussig graduated from Johns Hopkins, and she'd been kind of discouraged from going into medicine her whole life, which really just ironed out her resolve to continue doing it. And she missed out on a fellowship and was then given an appointment at the pediatric cardiology unit. It felt that, oh, dealing with these children with heart defects would be good work for a woman. Their children, they have heart defects. This sounds like something that'd be good for her. She really took that kind of slight and embraced it and became the expert on congenital heart defects and how they manifest. She worked with another woman at McGill University named Maud Abbott, who had a collection of post-mortem heart defects, and using a fluoroscope was able to figure out exactly how the blood flow was kind of interrupted or aberrant in her children who had these different heart defects, and try to figure out how that would manifest into their long-term recovery, whether they might get better, whether they would never get better, or whether they'd have sudden death. And this is a famous kind of picture of her near the end of her life, but this picture is a lie. And it's a lie because she had scarlet fever relatively early in life, and her hearing got worse and worse. And by the time she was in practice, she was mostly deaf. So she never listened to her children's hearts with a stethoscope. Ready, osteopaths? She palpated the heart defects through the chest wall of these kiddos. She would palpate to feel where the different, cycles of the heart would happen and where they went wrong. So just be aware, can you palpate heart defects? Yes. Is it easy? No, but it can be done. So she palpated these, and good advice for all of us, learn to listen with your fingers was one of her maxims to her students, even if they were able to hear and use a stethoscope. She wrote the definitive text on it, Congenital Malformations of the Heart, creating the field of pediatric cardiology. But at this point, all she was really able to do was prognosticate how quickly these patients would die. There wasn't much you could do for them. Fortunately, she had colleagues at Johns Hopkins, Vivian Thomas and Alfred Blaylock, who were experts on heart surgeries, or at least surgeries of the major vessels around the heart. They'd worked on surgical shock and done vessel rerouting to figure out a way to induce surgical shock in animals so that they can then learn to treat it, and then during World War II, help people who were experiencing shock to not lose so much blood volume that they would die. So Vivian Thomas was we'll talk more about him next week, but he was a black teenager who wanted to go to medical school but had his life savings wiped out and took a job at Vanderbilt for Alfred Blaylock, who was the surgeon there. They worked on shock, and Alfred Blaylock realized that Vivian Thomas, he'd been trained as a carpenter, had extraordinarily good hands. He had great surgical skill, took very little time to train him to do a lot of the research and a lot of the investigations that needed to be done for these cardiac procedures that they used dogs to induce problems with and figure out ways to solve it. So talking with Helen Taussig, she said, I'd like to come up with a way for my tetralogy of Fallot patients to reroute some vessels, because what I've noticed is if they have a patent ductus arteriosus, a connection between their pulmonary artery and their aorta, they actually survive for quite a while. But if that closes or they don't have it, their prognosis is really poor. So why can't we create an artificial connection so that more blood gets to the lungs and they stop being what were called blue babies, babies who are so cyanotic, their skin, their gums, their nail beds were very blue because of the lack of oxygenation. So Thomas and Blaylock got started on ways to work out how to do this, and they had to use smaller and smaller animals to replicate the smaller and smaller patients that they'd be dealing with when the day actually came. And the day came faster than they expected. A 3-year-old girl named Eileen Saxon, she was 3 years old, but she had tetralogy, and she had taken a much, very bad turn. I'm going to buy that back in. She was 3 months old, not 3 years old. And they had to do the procedure. Here's the problem. Alfred Blaylock, chief of surgery at Johns Hopkins, had never done this procedure on any of the experimental animals except once, and it didn't go well. Vivian Thomas, his black lab assistant, who was not allowed to enter Johns Hopkins through any of the main doorways, wasn't allowed to eat with the white students, faculty, and so forth, was the only person who knew how to do the surgery. So Alfred Blaylock scrubbed in and immediately stopped the surgery and said, I need Vivian here. And Vivian Thomas directed the chief of surgery in the procedure of this surgery from over his shoulder, giving him hints like, no, put that suture in this way. No, peel it back that way. Okay, suture there. And they weren't really sure if putting these tiny little vessels together had worked until they removed one of the clamps, and the people in the room have been interviewed multiple times since, said that this little girl just went flush pink all at once as soon as that clamp was removed. And that surgery, having been invented, became something that people came from around the world to get done. That procedure was used for a lot of children who had tetralogy of Fallot. And if you want to see Alan Rickman and Mos Def portray them, you will cry many tears. I was weeping openly at the end of this movie, but it was really good. So if you want to see a dramatization of it, Something the Lord Made is the name of the movie. And so they invented what was called the Blaylock-Taussig shunt. Now, Vivian Thomas, again, being black, did not get the credit that he deserved for pioneering the procedure, and very belatedly did get an honorary doctorate from Hopkins in 1976, and his portrait is present next to Blaylock's in the Grand Hall there. Now, Eileen Saxon lived for, I believe, a year or two, but the other people who came after her benefited from more and more experience, and eventually the outcomes were so good that no one was really dying after the surgery, and they stopped tracking mortality because a lot of the people who'd survived then had the actual defect repaired once the heart-lung bypass machine had been invented, and people could go in and actually repair the damage directly by removing the heart from circulation temporarily and fixing the problem in sight. So the next big advance was in transplantation. Now, transplantation is something that's been attempted throughout history. There's a really interesting history of blood transfusion, which I can't get into here, but blood transfusion was nuts. People had no idea what they were doing, but tried all kinds of animal to human transfusions and so forth. But transplantation, the first one was done. It was a kidney transplant between twin brothers. People knew that there was going to be some sort of a reaction against the antigens, but twin brothers worked well, and the surgeons who tried this got the Nobel Prize. But doing transplants from one person to another when you didn't have a redundant organ like the kidney, and when you didn't have somebody who was genetically identical, was a real problem. Now, at Stanford, there were two researchers, Richard Lower and Norman Shumway, who'd been working and working to try to come up with ways to do heart transplants, and they'd been doing a lot of canine transplant operations, and they thought they were just about ready to do a human operation when, to their amazement, someone they'd worked with earlier in Cape Town, South Africa, Dr. Christian Barnard, had actually done a human heart transplant. Now, the heart transplant worked, but the people survived for 2-3 weeks, maybe a month or more, very rarely. It was a very temporary fix because no one knew how to deal with the rejection phenomena. And so the bright, shiny new object of heart transplants became very popular briefly, but because the outcomes were not sustainable, and it's a pretty brutal procedure to heal from, only to die several weeks later, it lost a lot of interest. So quick bandwagon, followed by people dropping off of it. However, Shumway and others at Stanford kept on working on the problem, trying to come up with a way to deal with the immune issue, the rejection phenomena, and came across actively finding cyclosporine. And that was enough to shut down the immune response to the foreign tissue so that people could live. Now, it was going to compromise their immune system, but they were no longer going to reject the heart. And at that point, various transplants became much more feasible. And now, as you all know, we're at the point where the transplant procedures are not the problem. The problem is getting enough donors to actually get to all the people who are awaiting transplant. So availability is the issue now. So how are we dealing with availability? That's the real kind of holy grail at the moment, and it's by creating organs from donated cells. There's no rejection if you grow an organ from the stem cells of the person involved. So in 2006, a guy named Anthony Atala's team at Wake Forest were able to come up with a way to create an artificial bladder from the cells of a child who'd been born with spina bifida. His bladder was kind of perpetually contracted, but they were able to come up with new cells painted onto a scaffolding of collagen that then were able to be linked into the ureters and expand the bladder, and no immune reaction would occur because it was coming from the child's own cells. More recently, lab-grown tracheas have been done. And to no one's surprise, 3D printing of biological materials is now an active place of investigation to actually try to 3D print organs that can then be used for transplantation into the person from whom those cells were brought. And hopefully, a lot more cool stuff is going to be happening throughout your guys' career, making these transplants and other surgeries even more plausible and even more powerful. And that's it for today. Next up will be the last lecture in this talk, looking at excluded groups and missed opportunities throughout this entire history of medicine. Thank you very much. I hope you guys had a good time.